Good morning. Welcome to the Senate Committee on Commerce and Labor for the 81st legislative session. Before we begin, please be sure to mute your microphone when you are not speaking to minimize the background noise. Madam Secretary, please call the roll.
Senator Hardy? Senator Lang?
Here.
Senator Neal?
Here. Sorry.
Senator Pickard?
Here.
Senator Scheibel?
Here.
Senator Settlemeyer?
Here.
Chair Spearman?
Here.
And Senator Hardy's here.
Thank you. That's a good move, Senator Hardy. I heard that Jimmy Kimmel was looking for a sidekick, so good move. Okay, so Madam Secretary, I believe everyone is here. So I want to welcome our audience who's joining us remotely and anyone listening over the internet. Today we have a work session on Senate Bills 90 and 100 and a hearing on Senate Bill 139. I'd like to take a moment to go over some basic housekeeping. As you know, the legislative building is currently closed as a public safety measure to reduce the spread and infection rate of COVID-19 to the public. And so all committee meetings will be held virtually, meaning committee members, staff, and everyone else will participate either through Zoom, video conference, or by telephone. However, there are various ways members of the public can engage with us and participate throughout the process. These include registering to participate through Nellis, where you have the opportunity to testify on a bill or provide public comment during the meeting. You may submit written comment to the committee email address or fax number listed on the agenda. You may also share your opinion via the legislature's opinion of application on Nellis, or viewing committee meetings online through Nellis on the legislator's YouTube channel. To register on Nellis, simply click on the Participate button near the committee meeting date and time, and then fill in the required information, such as your name, the agenda item you're interested in, the organization you're with, and your position on the bill. Once your registration is submitted, you will see a confirmation screen, and you will also receive an email with the phone number and meeting ID to call at the time of the meeting. Just to note that while meeting registration is required to participate, it does not guarantee you will be able to speak. Just like in similar previous sessions, comment and public comment may be limited due to time constraints. I will announce the time frame. That's how many minutes we have for each segment: for, against, and neutral. It will be helpful if more than one person in an organization wishes to comment to remember ditto is a good response when someone has already covered your points. This will allow more people to comment during that time frame. When you're on the phone line, please pay attention to which bill is being considered and follow the verbal prompts provided by BPS staff so that you know which keys to press to raise your hand or unmute yourself. Staff will call on you to speak by the last 3 digits of your phone number. Detailed instructions for participating in committee meetings are also available on the help page, which is linked in the banner at the top of every page on Nellis. If you need assistance with any of these processes, or if you would like to receive electronic notification of the committee's agendas and minutes, please contact our committee staff at the email listed on the agenda. Any exhibits for the committee must be submitted in electronic format no later than 8:00 a.m. the day before the meeting to our committee staff. Contact information may be found on the committee page in Nellis. In addition, any person proposing an amendment to a bill being heard must first talk to the sponsor and let the sponsor know that you intend to submit an amendment. I will not entertain any amendments if the bill sponsor is not aware of the amendment. The proposed amendment must be submitted in writing 24 hours prior to the meeting. Please include the bill number, the statement of intent, and your contact information. When testifying, please remember to unmute your microphone and clearly state your name and the entity you represent at the beginning of your testimony. Please speak clearly and project your voice to ensure those watching remotely can hear your testimony. I promise you, if you project your voice so that people can hear you, that the mic will not bite. Please remember to turn the microphone off when you finish speaking. And as a reminder, to those who testify pursuant to Nevada Revised Statutes 218E.085, it is unlawful for a person to knowingly misrepresent facts when testifying before a legislative committee. A person who knowingly does so is guilty of a misdemeanor. The chair and any member may request a testifier to submit documentation supporting their testimony. To committee members, during these virtual meetings, when an agenda item calls for a vote, our committee will be using roll call to do so. When the committee secretary calls your name, please answer with a yes or no, so that there is no confusion. Also, if you have a question, please raise your hand through the Zoom application. And finally, all exhibits received prior to the meeting will be available on Nellis online. And so let's begin with a work session on Senate Bill 90. Mr. Marmorejo, please begin.
Thank you, Madam Chair. For the record, Cesar Melgarejo, Committee Policy Analyst. Senate Bill 90 is sponsored by Senator Hardy, and it was heard on March 8th, 2021. And Senate Bill 90 requires a healthcare licensing authority and health authority that determines, as a result of an investigation, that there are no reasonable grounds to believe that the provider of healthcare has committed a violation, to refer to the investigation as a review and evaluation in all records maintained by the authority. The bill provides that an investigation recorded as a review and evaluation is not an investigation for the purposes of related to education, employment, liability, or health insurance, or professional licensure or credentialing. Finally, the bill provides that this requirement applies to any investigation of a provider of healthcare conducted by the Healthcare Licensing Authority or the Health Authority as applicable before, on, or after October 1, 2021. And there were no amendments submitted, but it sounds like Senator Hardy has some clarifications.
Yes, sir. Senator Hardy, can you provide the clarification you spoke of earlier, please?
Yes, thank you, Madam Chair. I needed to clarify that the National Practitioners Data Bank only gets the complaints after the board has had a decision that documents an adverse decision. However, as we talked in the hearing, any form or application that asks if you are, quote, under investigation, unquote, still is the applicable challenge that we have currently, and this bill will correct that. And I appreciate your indulgence. Thank you, Madam Chair.
Thank you, Senator Hardy. Committee members, are there any additional questions or comments? Okay, I don't see any, so I will accept a motion, and this is just a clarification, Senator Hardy, not an amendment, correct?
That is correct.
So I will accept a motion to do pass on Senate Bill 90.
Move to pass.
I have a first by Senator Settlemyre. Do I have a second?
Second?
Second by, is that Senator Scheibel?
Yes, it is.
Okay. First motion made by Senator Settlemyre and second by Senator Scheibel. Is there any discussion on the motion? Okay. Madam Secretary, please conduct a roll call vote.
Senator Hardy,
Yes.
Senator Lang,
Yes.
Senator Neal,
Yes.
Senator Pickard,
Yes.
Senator Scheibel,
Yes.
Senator Settlemyre,
Yes.
Chair Spearman.
Yes. And let the record show that the motion passed unanimously. Senator Hardy, would you agree to take the floor statement for this? Senator Hardy?
Senator Hardy, you're muted.
I'm trying. Yes, I'll be glad to, in my own delayed way, apparently. Thank you.
Okay, thank you. I guess the one carryover from all of this is when we're talking in person, we're going to have to ask everybody to unmute if we don't want to hear them. So thank you, Senator Hardy. So let's begin work session on Senate Bill 100. Mr. Magalejo and committee, Sarah, do you all have the amendment that was proposed?
Madam Chair, this is Cesar Magarejo for the record. We don't have the amendment that was mentioned earlier. This would be an amendment in addition to what's provided in the work session document.
Okay. So what we'll do is we'll go through the hearings this morning, and I'll come back after the hearing to see if you all have had a chance to have the amendment, excuse me, and the amendment provided to the committee members so that they can address any questions that they may have. Okay. Senator Sievers-Gansert, we will move forward after we get the amendment, okay? Silence is consent. Okay. So let's begin now with a hearing on Senate Bill 139. That's Senator Scheibel and Brooke Maloth with Transgender Allies Group, along with Elliot Butler. So, Senator Scheibel, please begin when you're ready.
Thank you so much, Chair Spearman and members of the Senate Commerce and Labor Committee. For the record, my name is Melanie Scheibel. I am the state senator from District 9, representing the southwest part of Las Vegas. And it is my honor to be here today with Brooke Maloth, Eric Matson, and Elliot Butler to present SB 139 to you. This bill requires insurance companies to provide for the treatment of gender dysphoria, making sure trans people are treated equitably and with dignity. Before I turn it over to the advocates who are much better positioned than I am to talk about the bill, I want to let the committee know that I have been working with stakeholders, including Medicaid and PEB and the Healthcare Coalition and the Nevada Association of Health Plans, to address their concerns with the bill. And I appreciate that all of these organizations have expressed a very sincere desire and willingness to provide equitable coverage for their trans members. And I will continue to work with all of these organizations and other stakeholders to develop a consensus. And I plan to present an amendment at the time of the work session, should there be one. To answer the question on everybody's mind, yes, we have discussed some possible amendments, but no, we have not yet reached an agreement. With that, I will turn first to Ms. Maloth, who will walk us through the bill. She'll provide us with some background on the bill, explain the purpose and the policy proposal. Then I will turn it over to Mr. Butler, who will help us understand the challenges of confronting gender dysphoria with inadequate health coverage. And then we will get to hear from Mr. Matson, who will help us see how important and life-affirming adequate coverage can be for someone facing gender dysphoria. After these presentations, we will all be available for questions. And right at the outset, I just want to express my very deep and sincere gratitude to all three of these individuals who have not only taken the time out of their day to be here, but who have volunteered to share with us their incredibly personal stories. And I know that you will all be respectful and thoughtful with your questions, and I hope that you will direct most of those questions and all of the policy questions at Ms. Maloth and to me. And with that, it is my pleasure to introduce Brooke Maloth to introduce all of you to SB 139.
Good morning, and thank you for being able to be here this morning and to listen to what we have to say. I thank you for this opportunity to present the need for you to be able to pass SB 139. My name is Brooke Maloth. I am presenting this bill as a citizen of Nevada and not representing any organization, entity, or agency. For full disclosure, while I am employed by the Division of Public and Behavioral Health, my presence here and my testimony does not reflect in any way the views of the division or of the Department of Health and Human Services. I am experienced in transgender issues and healthcare policy on state and federal levels. I also have a deep experience in the Byzantine interplay of health insurance and healthcare delivery, and how that interplay often leaves patients outside of the conversations that leaves them vulnerable and left in harmful situations. First, a quick background on the history of gender-affirming healthcare coverage. Beginning in the 1980s, it was common for health insurance plans to have specific exclusions for any coverage of medical treatment to change or alter sex of a person. This type of exclusion was banned under Section 1557 of the Affordable Care Act. That document has been provided to the committee. In Nevada, the insurance commissioner issued a bulletin, it was Bulletin 15-002 on June of 2015, that interprets Section 1557 to mean that any procedure covered by an insurance plan cannot be denied to another person just because of their transgender status. For those plans that are self-funded and are governed under ERISA, they are still subject to follow the employment non-discrimination law under NRS 651.070 as detailed in the Nevada Legislative Council Bureau's opinion of September 3, 2015, provided to this committee as an exhibit, and provide coverage for gender reforming procedures to their transgender employees. In other words, if a cisgender woman has her hormone replacement therapy covered by an insurance plan, a transgender woman must also have her HRT covered. A plan that covers a medically necessary mastectomy for a cisgender woman must also cover a medically necessary mastectomy for a transgender man. Despite these laws and policies, transgender persons still experience denials of coverage. Bias still exists within claims departments and is still present throughout the bureaucracy. During 2020, I personally counseled an individual through multiple pre-authorization denials from the third-party administrator contracted with their employer's self-funded plan. Those pre-authorization denials for a medically necessary mastectomy led this individual to pay for the operation out of pocket, then submitted the claims for reimbursement, again meeting denial and additional denials to appeals. Escalating the issue to the company's HR department, this individual learned that the self-funded plan had specifically changed their coverage to include coverage of procedures such as mastectomies, yet the TPA continued to deny reimbursement. Finally, after 8 months of work by the employee and their HR representative, reimbursement was finally accomplished. This scenario featured a well-compensated professional that had scrimped and saved to have the means to pay for medically necessary surgery out of pocket for a procedure that was specifically supposed to be covered. Similar stories occur daily in Nevada with persons seeking medically necessary treatment but are denied by a faceless, biased, and historically discriminatory industry. Those denials are most heavily felt amongst our Black and brown sisters and brothers, whose intersectional marginalizations cause multiple barriers to health and opportunity. Insurers have a history of supplanting their judgment, applying their biases in place of physicians' judgment, best practices, and accepted standards of care, which constitute a discriminatory act. When insurers fail to cover medically necessary care, people suffer anxiety, depression, social ostracism, and a higher risk of suicide. SB 139 is designed to send a clear message to the greater healthcare community. Discrimination is not acceptable in Nevada. Let's also address the practicalities of what this bill does. It eliminates thinly veiled, biased, discriminatory exclusions of treatments for gender dysphoria for such things as voice therapy and facial feminization surgery. Denials for such treatments have been ruled discriminatory when denied by state employee healthcare coverage in Florida, in Oregon, and in Wisconsin, as well as in other jurisdictions ruling against insurance carriers and employer-based health plans. Those decisions have not only ruled that the plaintiffs be reimbursed for their healthcare procedures, but also included compensation for pain and suffering that amount in the hundreds of thousands of dollars. Attempts to use biased denials have cost far more than the coverage for medically necessary procedures would have been. Every healthcare plan in Nevada that excludes these procedures is risking paying far more in penalties if litigated than they would by providing coverage. SB 139 sweeps aside these exclusions and provides a level playing field for all healthcare plans. As all plans must include gender-affirming healthcare procedures, no plan can attempt to find a competitive advantage by not paying for these procedures. It validates employees that get their coverage through their employer or union by having the ability to access medically necessary care that meets their needs and offers relief from the symptoms of gender dysphoria, which allows the employee to thrive to the benefit of the employer. Historically, healthcare payers have had difficulties in projecting the anticipated costs for including gender-affirming procedures that had been previously excluded. Wild and fantastic estimates were proposed, sometimes through a biased process and ignorant understanding of the expected utilization. In one analysis I reviewed a few years ago, the actuaries assumed that every covered transgender person would have gender-affirming surgery every year for the rest of their lives. Keep in mind, these are once-in-a-lifetime events, and not every person who identifies desires or is medically eligible for these procedures. Actual utilization after implementation often resulted in the initial estimates to be wrong by a factor of 10. I suggest that estimates for fiscal impact of this bill have followed a similar unsubstantiated pathway. Additionally, it needs to be pointed out that this bill is not asking for free health care. Transgender people and their families pay into healthcare plans through insurance premiums and through employee compensation packages. We pay for coverage of medically necessary treatments. Having those unique treatments denied due to administrative bias is discriminatory. Those that are indigent and on public assistance are striving to be affirmed and to have the opportunity to seek gainful employment and thrive within Nevada, giving back to society. This bill seeks to eliminate this type of discrimination. Ultimately, using fiscal impacts as a reason to deny coverage through SB 139 is still discriminatory and in violation of federal and Nevada laws. Now is the time to recognize the needs of the transgender and marginalized community and welcome them into the circle of humanity by providing the necessary coverage to ease the suffering caused by gender dysphoria. I urge you to pass SB 139, and I am grateful for the time to be able to present this bill. Thank you.
Senator Scheibel, do you have anyone else?
I do. I would like to turn it over to Mr. Matson now.
Good morning, everyone. Can you all hear me well? Perfect. All right, so thank you, Senator Scheibel, for inviting me to speak in support of SB 139. My name is Eric Matton. I'm a 32-year-old paralegal for a financial advising firm based in Las Vegas, Nevada. I'm a husband, and I'm a soon-to-be father. So in March of 2018, my wife sat me down to watch Gender Revolution, a 2017 documentary that explores gender identity. As a hairstylist with a diverse clientele, my wife takes pride in creating a safe and loving space for her clients. So when one of her clients shared that they were in the early stages of their transition, my wife asked for suggestions of shows, articles, anything she could get her hands on to gain knowledge and become an ally for her client. What started as just another documentary ended up being life-changing. After the credits ended, my wife turned off the TV and turned to me. I was in tears. It took a moment for me to work up the courage to speak, but the first words out of my mouth were, "Do you think this is me?" I wasn't afraid of what my wife would say, but I was afraid that what this discovery meant for me was who am I going to talk to? Who do I turn to for information about hormone therapy? How do I afford the help I'll need? In early April 2018, I had my first appointment with a therapist specializing in gender identity. Luckily, my first therapy appointment and the 10 that followed were covered by my employer-provided medical insurance, with a small out-of-pocket expense to myself. Without that coverage, I would not have been able to afford 11 sessions at $150 each. One session alone was the equivalent of 2.5 weeks of groceries for my wife and I. After my first therapy session, I was referred to a clinic specializing in healthcare for the LGBTQ community. When I started my testosterone in May of 2018, that's when the medical expenses began to increase. Blood work and a checkup every 3 months for my first year to start, 0.5 cc's of testosterone every week for the rest of my life. Once again, my medical insurance provided coverage for it all and left me with small, manageable copays. Without coverage, I can't imagine what my wife and I would have to go without in order to keep up with the demands of hormone replacement therapy. When I hit my 1-year anniversary on testosterone, I began my search for a plastic surgeon to assist me in performing my masculine chest reconstruction, or better known as top surgery. After choosing a surgeon, submitting my medical records and letters of referral to my insurance, I underwent surgery in September of 2019 with the help of my insurance. For me, top surgery was a necessary step to have the exterior match who in my soul I know I was meant to be. Therapy provided me with clarity and helped me to build my self-confidence. Hormone replacement therapy continues to support the masculinization of my secondary sex characteristics, such as my facial hair and body fat redistribution. It's very hard to imagine what my life would look like had I not had the insurance to help cover the many aspects of my transition. I consider myself to be very lucky to have been surrounded by love and support throughout my transition. My wish for my fellow gender diverse individuals is that they feel loved and supported by those elected to help be their voice. So I humbly ask for your support of SB 139.
Thank you so much. And with your permission, Chair, we have one more presenter, Mr. Butler.
Yes, please proceed.
Hello, I'm Elliot Butler. I have been on testosterone for 1 year, and right now I'm in the process of trying to get top surgery. Right now, my insurance has denied my first letter from my referral from my doctor, and I have to raise $10,000 almost to get top surgery, which is a struggle lately because I have to work 4 jobs and also pay other bills. So with my insurance denying the letter at first, was kind of heartbreaking. I had to figure out ways to find fundraisers to raise the money for my top surgery. At this moment in time, I did get my referral letter from my therapist to review with my insurance to cover the top surgery. I'm in the process of getting my consultation on March 26th. So I'm hoping that the insurance company does approve, but right now it is looking very slim that I won't be able to afford the top surgery, and it's getting really difficult. But with my personal timeline with being on testosterone, I was able to afford the injections and testosterone through the clinic, which is a reasonable, affordable fee. And now that I'm just waiting to hear if I get approved or not, I just hope that you guys will proceed with passing this bill and helping all the transgender people in Las Vegas. Thank you.
Thank you so much. And Chair Spearman, that does conclude our presentation of the bill. I am happy to answer questions. I would also like to let everybody know that we do have a representative here from Medicaid, because I anticipate that there will be some questions about how this will affect Medicaid, and Mr. Young has very generously offered to join us to answer those questions on that side of the policy questions.
Thank you, Senator. Are there any members of the committee who have questions? And I see a reliable hand from Senator Pickard.
Thank you, Madam Chair. I just have a couple of technical questions, and Medicaid was going to actually be the third. As I review the bill, I noticed that when we go in and we start looking at the definitions, and then we refer to, or we require practitioners to abide by the definitions here. I wanted to get a little more information on this, so I looked up the DSM-5 and realized that though they are substantially similar, the definitions are different. And so haven't we created, by not following the definitions in the DSM-5 verbatim, have we not created a dichotomy that the providers are now going to have to struggle with? And how is this going to affect their ability to diagnose under the DSM-5 when there may be some differences?
So do you want to take that, Ms. Maloth, or do you want me to take it?
You go first, and why don't I follow up and fill in the gaps?
Okay. So a couple of different things. The first one is that I think that, this is language from LCB that matches other language in Nevada statutes. And I am not sure that it has to match the DSM-5 exactly in order for providers to be able to utilize the DSM-5 and also be compliant with our law. But we looked more closely at the WPATH standards, and the WPATH standards match these, I think, if not verbatim, then as close as possible to allow for consistency with Nevada statutes. And the purpose is to be consistent across insurance plans and to be consistent across providers. And I think, I don't know what the exact differences are with the DSM-5. Perhaps if there's specific language or something that's missing from the DSM-5 that you don't see in the bill, I could speak to that. But I don't think the differences are substantial enough to actually result in any kind of confusion about the care that people should receive and will receive.
I'm just trying to figure out if there are end runs that can be made around it because of the differences. The other question.
Well, excuse me, Senator, if you wouldn't mind, I can help allay your fears on that.
Sure, go ahead.
The DSM-5, for the record, Brooke Maloth, the DSM-5 is critical for the appropriate diagnosis of the patient. It does not set out a treatment plan. The treatment plan, within the scope of what is written in the both in the WPATH standards of care, as well as within the context of this bill, formulate the boundaries of what the treatment plan could possibly cover. So, to be able to apply a diagnosis from the diagnostic manual does not give enough detail on an appropriate treatment plan that really has to be tailored for the individual. Not everybody wants to have gender-affirming procedures done. They might be just happy with social acceptance and affirmation. Some people might want to have simply hormone therapy. It's a very inexpensive overall treatment to be able to have. Other people in certain situations may need to treat their symptoms a higher level of intervention and additional medical treatments. The same as what you might have in dealing with high blood pressure, heart disease. Not everybody's the same. Every patient needs to be able to have a treatment plan that specifically fits their needs and is able to treat their issues. And that's what this bill is trying to do.
Right, and I appreciate that. And because we've mentioned WPATH, that's a private organization. And I don't believe that Nevada has adopted their criteria within our diagnostic panel. But I'm not an expert in that. I'd be interested to know if this is intended to adopt that.
The WPATH standards, again, Brooke Maloth for the record, the WPATH standards are what are used within the framework. They are not strict guidelines. but they are standards. The same as we would have standards for any other type of medical intervention. And there are times, based on the patient, that trying to fit within those standards may, on rare occasion, have to be navigated in a different manner. This bill has the language to be able to put that into a context for an individual patient within an appropriate, experienced clinical pathway of providers to get to that medically necessary designation for a particular treatment. This is not an open door to anything and everything. This is a pathway to be able to have a desired result for that particular patient.
Sure, and I appreciate that. But it sounds like you're saying then that this does not adopt the WPATH standards. And I'm thinking, we adopt standards for two reasons. Number one, to give guidance. We start with a diagnosis, which is presumably going to be based on the adopted DSM-5. Then they're going to have to treat based on another standard. But if we don't adopt these standards and something goes awry, well, now we don't have an adopted standard to look at, and it creates confusion when this gets litigated. And so that's kind of the genesis or the crux of my question or my concern. And the second question I have, with your indulgence, Madam Chair, if I may. I read over the Bulletin 15002, and this seems to fly in the face of, the experience we just heard. The denial seems to fly in the face of this department opinion. I'm wondering because as I read this opinion, it looks like this legislation is ultimately unnecessary to the extent that we already have a legal ruling on this. Why wasn't this followed? Was this followed up? Did the department just fall down on the job? How did that survive?
Melanie Scheibel, for the record, and I think that you have kind of hit the nail on the head, that what people are experiencing in practice is inconsistent with the decision or the ruling by the commissioner or the Department of Business and Industry. And so I think that I'm not the first legislator to encounter this problem and come up with a legislative solution. And that's what this bill does, is it puts into law what the Department of Insurance or Division of Insurance has already said is their interpretation of the law.
And I completely agree with that. And we do unfortunately see that a lot. I'm just thinking, did we seek enforcement and the Division of Insurance, the Commissioner of Insurance, simply refused to enforce it? Or, if we already have a legal opinion, we often try to avoid adding law to existing law that is ignored anyway. How is this not an issue of enforcement if the law is actually already in existence, according to them?
If I may, Brooke Malak for the record, this is a typical bureaucratic puzzle. Because of how insurance works, that pre-authorization can go in and be denied, and because of the terms and conditions of the insurance plan, before a complaint can be made to the insurance commissioner, and I'm speculating here, but often what happens is that the process requires the individual to appeal the denial. And if the denial is appealed, then that may, depending on what is buried in the contract, be able to appeal the denial to a higher source, such as the insurance commission. From what Mr. Butler related, it has not gone to that point in the process yet. But that inherently is one of the ultimate issues. There may be a policy that is understood in the legal department of the insurance company. It may be understood by those that represent them in this building, and they say we are meeting the obligations of the law. But when the fact comes down to that person who didn't read the memo from 6 years ago, and is still automatically denying those things, arbitrarily or capriciously, I don't know, then we put that patient into distress and potential harm, despite it being illegal. What we're trying to do with this bill is to create a sweeping mandate that if you've got the letters of recommendation, if you followed that, the standards of care that mandate for top surgery, that you have a letter from a therapist, that you have persistent and insistent symptoms of gender dysphoria, and the best treatment is to be able to have top surgery in this particular case, that is medically necessary for the removal of breast tissue as a mastectomy for breast cancer. Why are we denying these things? It's a $5,000 to $6,000 procedure. It's not going to break the bank for the number of transgender people that exist within the plan.
All right, and I appreciate that. Madam Chair, I'll let someone else ask the question about Medicaid. I would like to know how this impacts that, but I don't want to monopolize any more of the time. Thank you for your indulgence.
Vice Chair Neal, Chairwoman Spearman had to step out for a second.
I just get back. I see Dr. Hardy. Senator Pickard, you were finished with your questions, correct?
Yes, Madam Chair. I felt like I've taken enough time. I'll let someone else ask the question about Medicaid impact.
Okay. Yeah, because I was considering getting a buzzer to put on the side of your desk. A red light would light up when time's up. So
I probably need one. Thank you.
So Senator Hardy.
Thank you, Madam Chair. I'm going to ask a little more basic thing. When we talk about medically necessary, so we don't do mastectomies or build up breasts for plastic surgery that aren't medically necessary, and so somebody ends up having to pay for it out of pocket. And so I'm just kind of trying to figure out the definition of medically necessary. What I'm hearing is medically necessary is to have the person hopefully conform to their feeling of gender affirmation or confirmation. Whereas most people, if they go get a breast implant, for instance, that is not covered by insurance because it's, quote, not medically necessary, even if they're a person that works in the casinos with, I'll call it a prominence that is attractive. So that's one question I have, and then I'm going to ask a very basic question, and I don't understand. I've struggled with the name spelling that we have, but I'm seeing that on our participants. But the surgery type that you're explaining is apparently an abbreviation, and I would love to have it spelled as well as defined with the words that I don't know what the name of the surgery is. So you're using it, but I don't know what it is.
For the record, Brooke Malak, Senator Hardy, can you point me in a better direction on which term, which abbreviation of the procedure that you're referring to so I can better explain?
Well, just give me the procedures you're talking about, and then I can write them down. Because you're using, I think it's an abbreviation or an acronym, but I can't spell the acronym. I don't know what procedure you're talking about.
This is Melanie Scheipel, for the record, and I think I understand Senator Hardy's question. And I'll go from the second question first, then back to the first question, and say that the point of this bill is to cover any number of different procedures. And science improves, medicine improves, and we develop new procedures on a regular basis. One of the procedures that we did talk about during testimony was commonly referred to as top surgery, which is a procedure for people who are born and assigned female at birth. So they have breast tissue and they want to have that removed, and they have to have that removed in order to affirm their gender, which is actually male. And so it is akin to a mastectomy, but it could take different forms for different people. Some transgender men might need both breasts completely removed. Some transgender men might only need them reduced. Other transgender men might need their breasts removed and some kind of masculinization reconstruction on their chest. And the point of the bill is to say that whatever that individual needs, as explained by them and their doctor. So we're not having people walk into a clinic and pick from a menu and say, these are the things that I want. They go through that process that our advocates talked about with a therapist, with a plastic surgeon, with an endocrinologist, and they determine which procedures exactly are necessary for that person and in what time and in what order, so that the whole team can come together and say to the insurance company, this is what this person needs in order to be whole, and in order to live in the body that they have. And so I think that the short answer to your question is that it could be any different number of procedures. The longer answer to your question is that the one we were talking about is top surgery, and that would include, different types of mastectomies and chest reconstructive surgeries. It could also include breast implants for trans women. It could also include vaginoplasties, which is kind of the creation of a vagina, for lack of a better term. It could also include something like what we call a tracheal shave for trans women who have a very prominent Adam's apple, or I don't know what the technical term is for an Adam's apple, but the tracheal shave, helps to smooth out that line. We might also talk in testimony about facial feminization surgery. And I would also be happy to follow up offline and talk about, some of the various procedures that trans people today are able to access, and some of the new procedures that are becoming accessible, that are being invented quite literally every day. And I hope that helps to answer your question.
It's even more basic than that. You're using P-O-P, POP surgery?
Yes. For the record, Brooke Malath, it's top surgery as in above the waist surgical interventions, as opposed to bottom surgery, below the waist types of surgery. It's just a common vernacular within the transgender community and those that are medically attending to them. You also had a question about essentially breast augmentation. And what is considered medically necessary and covered by insurance companies is breast augmentation for chest reconstruction for a cisgender woman after a mastectomy, in order to be able to regain the contours, the physical manifestation of how they presented before they had to have their breasts removed. The breast augmentation for transgender women is really only necessary if the effects of the feminizing secondary sex characteristics induced by hormonal therapy have really not made an effect. And that only happens after the individual has gone through a male puberty. For young people that are coming up that have identified and have been started treatment for their gender dysphoria at an early age and been put on puberty blockers, which again are already covered under the memo from the insurance commissioner in 2015. Those puberty blockers will arrest the puberty until it is deemed perhaps appropriate for that individual if they want to continue on that pathway of gender transition. So then that a hormone replacement therapy regimen can be introduced at an appropriate age. So they only have to go through one puberty. And I will attest personally, having gone through 2 puberties, 1 is enough for anybody. So, it's it can benefit the insurance community overall by allowing an appropriate pathway early on through puberty blockers, hormonal therapy, etc. And that can mitigate the need or even the desire for later surgical interventions, which is better outcomes for everybody.
Well, I appreciate, as far as I know, there is not a, quote, procedure that is medically termed POP procedure. So I appreciate Senator Scheibel, you elucidating and enumerating the surgeries and keeping open the door for the new inventions in surgeries, because it helps me understand the generic term, I guess you'd call it, or the vernacular POP surgery, because there isn't a POP surgery, to Senator Pickard's point about, where does it fit into the EMS 5 or any of the other vernacular. But I appreciate the clarification. Thank you, Madam Chair.
Thank you. Vice Chair Neal.
Thank you, Madam Chair. I wanted to address my questions to Mr. Young. Is he still on?
I'm here, Senator.
Okay, great. Okay, Mr. Young, so this bill really reminds me of the sickle cell bill I had last session. And I wanted to talk about this, the prescriptions. What are the costs of the prescriptions that are going to go into this? Because I know in the bill I had last session, I had to specifically get into the formulary. I had to prescribe in statute what I wanted to see in terms of drug access through Medicaid. But I didn't see the language in here. Is that contemplated? Is that something you guys are going to cover or deal with through Ms. Finney?
Mr. Young, you're muted.
Dwayne Young, Deputy Administrator for the Division of Healthcare Financing and Policy. Senator Spearman, to you, through you, the chair, to Senator Neal.
Mr. Young, just go direct. Just go direct.
Thank you for that, Senator. Senator Neal, to answer your question, Medicaid policy, when it is administered, covers both fee-for-service and managed care. Now, there are differences, and correct, the prior authorizations are the same because the managed care organizations do present on our Drug Utilization Review Board, but there are differences in what is preferred and non-preferred because each Pharmacy and Therapeutics Committee is run separately by its own NCO and by the state through its Silver Script States Board. In this particular bill, medications are not called out, and we worked with the senator because those medications are already covered. And while there may be some nuances and criteria about what is preferred, there is an acceptable alternative in each category and of pharmaceuticals that are covered for these drugs. What the state's fiscal note refers to is there are additional services, and as you all are aware, this fine body passed the governor's executive budget in 2017, which added these services to the Medicaid Chapter 600 on physician services. There are some services that are not currently covered by Medicaid. And because there is a nuance, as Dr. Hardy so alluded to, of what is considered medically necessary by both our fiscal agent and by the managed care plans that relate to some of the more cosmetic procedures, voice therapy, and hair transplantation. And so those services are represented in our fiscal note. I will note, though, that we have spoken with the sponsor and to work through some of those issues so that to align it more closely to our current policy.
Thank you for that, Mr. Young. And then my second question to you is the FMAP. So you had that in your fiscal note. So so typically there's like a contribution rate. So what's going to happen with the federal contribution rate in this scenario?
Again, Dwayne Young for the record, Senator Neal, thank you for the question. The FMAP is applied based on a person's eligibility and aid category. So for instance, if they are the traditional MAPIT population or medically disabled or blind population, they'll have around what is a 66% FMAP. If they are newly eligible, it will be 90%. And so we have not had a great number of these cases. And so I do believe that they fall across all FMAPs, but happy to follow up to see what specific trends regarding FMAP for the cases of gender reassignment we have already had.
Thank you for that. Third question, for plastic surgery, what is the provider rate for plastic surgery in these cases?
Again, Deputy Administrator Dwayne Young for the record. Again, thank you for the question. I do not know our physician rates offhand, but I will tell you that plastic surgeons are enrolled as a part of what we call Provider Type 20, our physicians group. And so they are paid no differently than any other physician that would be performing services. And also just to clarify, Medicaid does not allow federal reimbursement bars certain plastic surgery in certain instances. And what has been referred to here as the top surgery, we do pay for plastic surgeries in the cases that Ms. Maylap have pointed out as why there is a medical need for those services. And so that is covered as part of what's considered the top surgery.
And so you're not off the hook yet. Madam Chair, one more question. I just, because this bill really made me think, do we cover plastic surgery for cancer patients who have had a double mastectomy? I know it's an offshoot, but it made me think, do cancer patients get plastic surgery under Medicaid now?
Again, Deputy Administrator Dwayne Young, I can look at bring back the specific instances in which that would occur. If there is a medical necessity need for those services and the physician has gone on record as to it being medically necessary, then those services would be applied. I think that one of the interesting things I think we've argued in the history of Medicaid is the definition of medical necessity and how that applies. And Dr. Hardy could speak to this so much more better than I could, but as a physician, he knows that the physicians have to attest what the absolute medical need is for surgery as part of the prior authorization process. And then that surgery is approved based on that definition. And I think that, of course, some cases there will be denials because it did not meet the threshold of medical need. And in other cases, there will be approval because it did meet that threshold of medical need.
This is Senator Scheibel. I'm just going to cut in for a second. I don't want to speak for anybody else, but something that might be some good food for thought in my research on this subject was that we found that there were some times when people when plastic surgery was covered for things like accidents, if somebody, broke a limb or has some kind of, traumatic injury to some part of their body that required both internal and external repairs. Sometimes literal plastic surgery has been approved in those cases.
Thank you for that. Because honestly, when I saw medically necessary, I had a bill dealing with a population that was roughly about, I think, 2,000 people in the state. And the private organizations that were drawn into the bill by some of the chapters really tried to get me to move away, because I had comprehensive care, right, which has a total different medical meaning, to seek comprehensive care. And they literally spent a couple of months in the session to get me to change it to medically necessary. And my understanding, them getting me to try to change it to medically necessary was so that they could reduce what they covered and give them some wiggle room on what they weren't going to cover. And so when I read this language, you know, it looks good, sounds good, but you may find that the application of those two words gets you into a medical fight of what you say is needed in your interpretation, and then what a doctor then says they're going to do. And so I'm saying this because I traveled this road, and I'm just putting out some caution there that if there's already bias, these two words are going to make you have to fight. Just putting that out there.
Okay. Vice Chair Neal, is that it?
Yeah, I mean, what else could I ask?
Okay. I need you and Senator Pickard to stop drinking from the same water fountain, okay? Because it's spreading. Senator Settlemeyer.
Sorry about that. We're having an argument over who gets to unmute my mic, either Caesar, you, or me, or whatever. So I apologize about that. I was just curious. I'm trying to make sense of some of the fiscal notes. It sounds like this is already required by law, but yet some of the counties, like Clark County, is saying it's a $1.5 million fiscal hit potentially. And I'm just curious, are we the first state to bring forth said language in that respect? In other states that have had this language, if they are any states that have had this language, how much has it raised insurance premiums overall? You know, I remember when we did the autism one, you know, they all swore that if we did the autism bill, the sky would fall and everybody's rates would double. And it actually ended up being $1 or $2 as far as the increase that was really necessary to handle that. And it was obviously more than worth doing to help people out. So I'm just curious whether states have had similar language.
If I may, I can address that. This is Brooke Malek for the record. We would be the first state to be able to have something that is this broadly mandated. There are many states that are still refusing to follow the guidance of the Affordable Care Act. Although the federal law does still apply, it just makes the process for an individual patient to go through a complaint and an appeals process much more difficult. Regarding the overall impact, when the memo came out in 2015 and mandated the expansion of procedures that were already being covered by insurance plans for cisgender people, and now because of the Affordable Care Act and our memo, it mandates that you've got to do those for transgender people as well. You know, it's the increase was measured in pennies. The increased cost was really pennies. A study out of San Francisco, when they expanded, it ended up that it cost the individual member an additional 3 cents per member increase. When we looked at other plans here in Nevada, it comes out to a rounding error. You know, it's when we're looking at a $20 million payout from an employer, you know, for their overall employee packages, and serving their transgender employees and the employees' families, the expense is under $50,000, you know, it's a decimal point of a percentage rate. It's pennies for this life-affirming, very beneficial type of treatment. What this bill does is it expands very, very slightly a few other types of procedures that are considered medically necessary by WPATH in their standards of care, and whose exclusions have been challenged in the courts throughout the country, and the plaintiffs have won, costing the insurance plans hundreds of thousands of dollars in penalties above and beyond the cost of actually paying for the procedure. So in one sense, this bill is to insurance companies' best interest to be able to remove that potential litigation where they're going to lose and have to pay hundreds of thousands of dollars of penalties. Let's make sure that we can help direct that money to the patients who need it, rather than having to spend it in court battles, signing up court time, going to lawyers, that reaches the same outcome as what this bill does, which is let's pay for medically necessary procedures. That's all we're saying here. The bill is designed to be equitable to all of the stakeholders, to the health plans, and to the patients, and to Medicare, and the citizens of Nevada. Let's be able to bring transgender people into that circle of humanity and treat them for their medically necessary needs, the same as we expect it for any cisgender person, that those medically necessary needs are met. Let's remove the administrative kerfuffles. Let's remove the administrative barriers and the biases that have existed for years.
I appreciate that, and thank you. This is Senator Settlemyer, for the record, for allowing me to ask that question, Chair. I had an additional question, if I could, Chair.
Yes, go ahead.
Thank you, Chair. In that respect, what are we going to do about, unfortunately, the definition of medically necessary? Is there any provisions in law? Because unfortunately, I know none. Unfortunately, I've known individuals who have sadly found bad doctors that were willing to allow them to do things that weren't medically necessary. So in other words, I can find a safety and comfort in what you're discussing, but sadly, we already have situations where people will go find doctors to allow them to have surgeries that are merely, non-medically necessary and purely aesthetic, and therefore they find a doctor willing to give them that excuse. And what type of penalties in law exist? Will those some penalties cross over in this realm, so that if we find out people are unfortunately gaming the system per se, how do we deal with that?
This is Melanie Scheibel, for the record, and I think there are a couple of different ways to deal with that. One of them would be through, medical malpractice statutes. Another one would be through fraud statutes, because a doctor who is fraudulently approving procedures, writing prescriptions, fraudulently representing to an insurance company that something is medically necessary that's not, would be liable for that fraud. And I also want to point to what I think is a really important part of the definition of medically necessary as it's written in the bill. It starts on page 3. It's part of section 1. But if you look at page 3, line 19, part of medically necessary includes being not primarily provided for the convenience of the patient or provider of healthcare. And I think that is a bar to overcome for anybody to prove that what they are doing is not for their convenience or for their provider's convenience. And I think that kind of strikes at the heart of the issue that you're asking about, and that a couple of other members of the committee have asked about, which is how do we separate people who just want this procedure because they want it versus people who need this procedure because they actually experience gender dysphoria, and having a procedure or going through a surgery will alleviate that dysphoria. And I think that, I'm open to amendments. I'm open to working on this definition, but I think that the difference between need and convenience is a good barometer. And that is one of the safeguards that's already written into the bill to ensure that providers have some guidelines to what is medically necessary. They can't just say, I'm a doctor and I say it's necessary. It's, I'm a doctor, I've evaluated points 1 through 5, and this is medically necessary.
This is Senator Settlemyer again, and I appreciate that answer, Senator. And again, I just worry not about the true cases we're discussing, but about, unfortunately, bad doctors and bad actors out there. I mean, could they, potentially they could use this and say, hey, I'm getting older as a guy and I'm tired of losing my hair, so I just claim this somehow and then automatically get some Rogaine or something paid for as part of the insurance or something of that nature. And I'm just worried about those type of potential loopholes that sadly bad people can do, not individuals that we're discussing that need some assistance. So thank you for that.
So, sorry, was that another question that you want me to respond to?
Not really, Senator. I'm just trying to
Okay.
wrap my hands about how to try to deal. And frankly, I'll be honest, I have to go through some of these terms because a lot of them listed on the first page. I have no idea what some of this even entails potentially. Thank you.
Sure.
Are there any other questions from the committee? I don't see any other hands. So this is probably going to be a comment and a question rolled into one. Senator Scheibel, this is a really difficult bill. And it's difficult because you're dealing with a science that is relatively new. And whenever things are new, sometimes they're scary. And I think that's a historic fact. There once was a time when, in the early 1900s, when there was a supposition that Black people were genetically inferior to those of European descent. And they proved it in various and sundry ways, to which we found out later that wasn't true. So as science advanced, we've been able to kick that to the curb. The only thing we haven't been able to deal with now is the residue of racism that we incurred because of that. I'm thinking back on the first bill I had when I came to the Senate. That was one that would include transgender persons into the hate crime statute. And I remember some of the questions that I got, well, how do you know that they're really transgender? Maybe they just stand up at a concert and say, I'm transgender, and then they start a riot. And I'm like, no. Because once they make the transition, that's where they are. The other thing that I guess I want to say is, as we try to wrap our heads around this, from my seminary years, I remember that there once was a time when people who had some type of physical disability were not allowed to take communion because it was postulated that they had that because there was something that God had against them. And I mention that because I'm sure that the, quote, religious aspects of this will probably come into play. Those are things that we probably can't do anything about because what people think, they think. Yesterday, we heard a bill, Senator Orenshaw brought a bill about children who were in facilities where they had some type of emotional challenge. And within the bill, and some of the testifiers mentioned that the medical doctor and the psychiatrist work together to try to figure out what would be the best, not just diagnosis, but the best treatment. So here's the question. In this bill, and I'm sorry, maybe it's there and I didn't see it. Is in this bill, is there anything that would say that one of the things that you have to overcome is a doctor, and a psychiatrist, psychologist, somebody would have to work together in determining, quote, what would be medically necessary. And before you answer that, let me say this. Because we know, unfortunately, we have never dealt with the number of trans women who are killed. And they are killed because of who they are, which is one of the reasons why we have the hate crimes piece. So if a psychiatrist and a medical doctor are talking about this at the same time, and I have a friend who's a plastic surgeon, and one of the things that they do when you talk about cancer patients is it's the way the woman sees herself, and is that going to be something? Is that mental image, that psychological image, going to diminish what she can do because she sees herself differently? And we also know that there have been women who decided to die with breast cancer rather than get a mastectomy. So the question is there anything in this bill that would require both mental and physical doctors to work together to establish what would be medically necessary?
Thank you for your comments and your question. And I really appreciate your insight into this, and I agree with you. And the short answer is I think that there is, because in working on this bill, in talking to people who have been affected and talking to the healthcare plans, I don't think that there exists a provider network that would approve these procedures or these treatments without the sign-off from both a mental health professional and a physical health professional. That is something that can be written into the plan, that I think would be written into the plan. I think you also touch on an important issue that we face of a provider shortage. And I can't solve that problem with this bill. I can't ensure that we are going to have enough providers here in the state of Nevada to treat all of the people, especially members of other marginalized groups and people of color who experience gender dysphoria. And I wish that we could do that with this bill, but I do think that this provides a groundwork for everybody to have their insurance cover these procedures so that we can attract more providers to Nevada. And the bill is not designed to tell insurance companies how to evaluate what is medically necessary, other than the five factors to consider. And I guess what I'm saying is I would certainly hope that everybody who is utilizing this bill or who is benefiting from this bill has a team of experts by their side who is helping them through this to get the best care possible. But I also don't think that we should be setting up a system that that further prevents them from getting adequate care if they can't find all of the providers that they need and all the providers that they deserve. And so it provides some flexibility for Nevadans to work with the doctors that they have and work with the doctors who they can find, and get their insurance companies to help cover the cost of these procedures and treatments.
Thank you. And just something to maybe think about, not to add another barrier, but maybe there is some type of a compromise that would set a standard for medically necessary that includes mental health and physical health. So that could just be something to consider. And the last thing, I think Senator Settlemyer brought up a good point. What about people who are going to game the system? Who would game the system? Is Mr. Young still on? I think so. Mr. Young, let me ask you this question. Were this bill to pass, would this be the first time that someone would try to game Medicaid, or would this be the first time that there would be Medicaid fraud? Just a question.
Senator Spearman, Dwayne Young. for the record. It would not be the first time that Medicaid has experienced fraud, waste, and abuse. And we do have a whole unit that is dedicated to rooting out fraud, waste, and abuse within Medicaid.
What does that amount to? I mean, is that like $1,000 or $2,000? What does that look like? Because I'm trying to establish if there's going to be a precedent that we've never dealt with before, or if this is something that the system expects based upon some type of an algorithm or something like that. So talk to me about that.
Senator Spearman, if I may address your question in two parts. The first part, and again, Dwayne Young for the record, the first part being that, yes, Medicaid experiences $1 million of fraud, but it's spread across multiple provider types and multiple disciplines. And happy to provide that data in that report. I will speak to this particular set of services. Within Medicaid Chapter 600, Section 7, on page 3, we do have guidelines that assuage some of the other earlier fears that they do have, those seeking gender reassignment surgery do have to have a letter that's separate opinions from a psychiatrist or psychologist, as well as a medical doctor. Those two letters have to also state and attest that they have performed certain levels of therapy, and so as well as medical interventions before qualifying for the surgery. So the policy as it exists now is fairly rigorous to ensure that an individual has been diagnosed with gender dysphoria disorder and has sought several levels of treatment prior to having this surgery paid for and authorized by Medicaid. So there are safeguards within the policy. I will not stand here before you and say that our policy is perfect by any means, but Medicaid staff have done their due diligence in meeting those WAPAF standards that were mentioned earlier to assure that those receiving the surgery have followed the appropriate steps and have aligned with other policies and procedures within the Medicaid chapter.
Okay, thank you, sir. This is my last comment, and then broadcast must prepare to move towards public testimony, and the first one we'll go to would be 4. But here's my last comment, and this comes as no surprise, I'm sure, to Ms. Maylock and anyone else who works with DHHS in the LGBTQ space. I continue to be appointed because of the lack of diversity, not just in testifiers, but diversity, geographic diversity, someone from the South and someone from the North, diversity based upon ethnicity, because another thing that people in the LGBTQ community really don't like to admit, but racism exists there as well. And it exists if you are a white gay man. You can still have the same privileges of any cisgender white man, because nobody will know who you are unless you tell them or unless you act like that. But for people of color, then there's that intersection of gender identity and race that comes about. And there's no way to compensate for policy to compensate for that unless you have those eyes, those lived experiences at the table. And so right now, in my opinion, it's lopsided because we don't have diverse lived experiences at the table. That's my own beef, but I've said it before. And I will be glad when we come to the table and we can say that there is diversity in this part of what DHHS deals with. Lived experiences and representation matter. That's my comment. It's not against you. It's just the way the system is. And I think that the system needs to change. Somebody needs to change the system and recognize that there are diverse opinions. And you can only get that from people who are diverse, or at least people who have worked with diverse communities and they have some credibility. Because one of the reasons I say that is because if this does pass, you will need people in the community who have credibility to talk about what this looks like, to explain, the yes, no's, or no, you don't do this. Yes, you might check this out or whatever. And so if you don't have that right now, it's going to be very difficult to get it later. And I see see Senator Hardy's hand up. Yes, sir.
Thank you, Madam Chair. So if I'm understanding this correctly, this doesn't just affect Medicaid, but I think it also involves insurances, and I'm not sure how it affects the ERISA plans, but I think it's bigger than Medicaid, and I just want to make sure that I'm understanding that right.
Yes, this is Senator Scheibel, and you are correct. This would not just affect Medicaid. This would affect all insurance plans. And in fact, I think we will have a couple of providers on the line who are testifying today. And in fact, I did want to let you know that the Nevada Association of Health Plans is in support of the bill. I don't think they were able to stay past 9 o'clock to testify, but they are in support. And you'll hear from some other medical professionals, including provider groups that are also in support of the bill, who are also affected by the bill.
Thank you.
Okay, so broadcast, let's go now to the telephone lines, those in support. And we will have 30 minutes for those in support, 3 minutes per person. And if someone has already covered what you want to say, after you say and spell your name, feel free to say ditto. That way we get more people who are able to comment. And for those who think this is only something that happens because we are working remotely, I would encourage you to go back and look at any of the committees from last session, especially the ones that I chaired. We do the same thing because we're always under some type of time constraint. So this is nothing new for the remoteness of our operations. So broadcast, 30 minutes, 3 minutes per. Thank you.
Thank you, Chair. Good morning. To testify in support of SB 139, please press star 9 now to take your place in the queue. Caller with the last 3 digits of 005. Please slowly spell and state your name for the record. You have 3 minutes and may begin. Caller with the last 3 digits of 005. Please press star 6 now to unmute yourself. Thank you. You have 3 minutes.
My name is Randy, R-A-N-D-I, Lampert, L-A-M-P-E-R-T, and I am representing myself as a pediatrician in the community, and I would like to speak in support of this bill. As a pediatrician, I know from my practice and from data in the literature that youth that have untreated gender dysphoria suffer from increased depression and anxiety. In fact, their rates of suicide attempts range from 30 to 50%, compared to 14% in cisgender youth. With gender-affirming treatments, these rates drop to the 14% of their cisgender peers, and other mental health measures normalize. The American Academy of Pediatrics supports early gender-affirming care, including social affirmation, access to mental health treatment, legal affirmation, and when age deems appropriate, medical and surgical treatment. It is important to note that most treatments recommended for young people are completely reversible, and pretty much all treatments under the age of 16. And I state this in anticipation of arguments against these treatments for youth. This treatment is not accessible for most people if it is not covered by health insurance. This bill will increase access to life-saving treatment for young people in Nevada. Thank you for your time.
Caller with the last 3 digits of 837. Please slowly spell and state your name for the record. You have 3 minutes and may begin.
Thank you and good morning, Chair Spearman and committee members. This is Kent Irvin, E-R-V-I-N, with the Nevada Faculty Alliance. Faculty advocated with the Public Employees Benefits Program back in 2014 for coverage of these services to treat gender dysphoria, and those started with PEB in 2015. We support SB 139. It is a very modest expansion of the covered services for PEB, adding only the voice therapy and some additional services for members under 18 years of age. You would have to ask PEB for details, but our best estimate of the cost to PEB for these services in total now, before the bill, is less than 0.2% of all medical claims. So it really is a small cost for these vital services. Thank you very much.
Caller with the last three digits of 683. Please slowly spell and state your name for the record. You have 3 minutes and may begin.
Good morning, Chair Spearman and members of the committee. For the record, my name is Braceda Castro, spelled Breiceda, and I am the Economic Justice Program Manager with the Progressive Leadership Alliance of Nevada, here in support of Senate Bill 139. As a queer woman of color, I'm lucky to have a family that supports me, but other friends and family have been displaced from their homes because of their sexual preference and gender identity. I mention this because it's real and it's happening to loved ones, meaning they have another worry about finance. Housing and healthcare are basic needs. Vulnerable groups require healthcare based on medical necessity and must not be denied coverage based on external biases and discrimination. Medical providers must have the discretion to treat vulnerable patients without the interference and bias from insurance providers. Public and private insurers currently Public and private insurers currently have considerable discretion and routinely ignore or bypass medical expertise in rendering coverage decisions without adequate justification. We urge your support. Thank you.
Caller with the last three digits of 192. Please slowly spell and state your name for the record. You have 3 minutes and may begin.
My name is Brian, B-R-I-A-N. Last name Pence, P-E-N-C-E. Thank you, Madam Chair and Senators, for hearing me this morning. I wanted to support SB 139 on behalf of my family. We have a transgender son who started his transition about 3 years ago, has been on hormone therapy for about 18 months, and is currently scheduled for top surgery in May. All of the expenses for the transition, the hormone therapy, endocrinologist visits, and the top surgery that is scheduled have been denied by our insurance. So we are in the lucky position of being able to afford this. I mean, we will go into some debt to pay for it, but we are going to be able to afford it and pay for it so that our son will be able to exist as a healthy individual, healthy man. And I just wanted to reiterate how important it is to get insurance companies to accept these kinds of coverages and to reduce denials, because yes, we can probably fight the denial. We can try to go through legal means, but again, that throws more cost to us to get this procedure covered. So again, please support Senate Bill 139, and thank you for your time.
If you recently just joined us, we are in support of SB 139. To testify in support, please press *9 now to take your place in the queue. Caller with the last three digits of 794. Please slowly spell and state your name for the record. You have 3 minutes and may begin.
Good morning. My name is Albi, A-L-B-I, Smedley, S-M-E-D-L-E-Y. I'm a proudly non-binary, transgender, and Asian American person born in Las Vegas. I'm a CCSD educator. I teach high school. This is my 7th year teaching. Former small business owner, and I run a small grassroots activism group in Vegas called Trans Vegas. And I urge everyone to support SB 139 and consider the human lives that the bill affects. Healthcare plans that exclude gender affirmative care are discriminatory and dehumanizing. When something so fundamental and so necessary as healthcare for basic needs is not covered by your trusted employer, it's an entirely demoralizing experience. This bill is essential to ensure consistency among insurance plans and to normalize the way that healthcare providers work with trans people. I'm employed by one of the largest employers in the city, in the top 10 Courtney School District, and I've had my own struggles with healthcare. My insurance had a blanket exclusion for all gender-related healthcare up until about a year ago. And despite this, even though some of that is covered now, I still pay out of pocket for all my hormone therapy and diagnostics. I just got a bill last night for $300. And it's difficult to actually go through the process to get those things covered. And the plan still includes a blanket exclusion for any surgery-related care. And this is the only substantial health care I've ever sought coverage for, and surgery-related care is completely unfeasible for me financially right now, and that's something I cope with every day right now. So I face these struggles every day, and I consider myself to be in a relatively privileged position. So people who are in historically marginalized populations, more so than I am, they need this support from the top down. So I can't stress again the dehumanizing effect of seeking care for fundamental health needs and being unsupported by your employer, your insurance, or your government. So please consider supporting SB 139 so that residents of Vegas will get the same levels of care as everyone else. Since I have a second, I'd also like to say that living your life authentically as a trans person is empowering and affirming. It comes with societal stigmas, judgments, and some inner turmoil. So to suggest that people would be willingly going through those processes to game a system or something it minimizes those experiences greatly, and I think it's a dangerous argument to make and road to go down. Thank you very much.
Caller with the last three digits of 069. Please slowly spell and state your name for the record. You have 3 minutes and may begin.
Hello, Chair, Vice Chair, and committee members. This is Andre Wade, ANDRE, WADE, with Silver State Equality. In short, I would just like to state that we support SB 139. Thank you, everyone.
Caller with the last three digits of 695. Please slowly spell and state your name for the record. You have 3 minutes and may begin.
Good morning, Madam Chair, members of the committee. This is Holly Wellborn, HOLLYWELBORN, Policy Director for the ACLU of Nevada, testifying in strong support of this legislation. Thank you to Senator Scheibel for bringing this bill forward, and to the presenters and everyone who's testified today for their meaningful, thoughtful testimony. I think that Ms. Malak did an incredible job of laying out some of the legal guidelines, the civil rights aspects of this, but I do just want to add that, yes, indeed, the Division of Insurance's bulletin does correctly state the law. This bill comports with requirements of Title VII, but it also provides us with a state statutory tool when we're litigating these cases. The ACLU nationally, we've been successful in courts across this country litigating this in a variety of different states, but having that extra protection in state laws insulates us from any future changes at the Supreme Court level should that happen. I am incredibly grateful for this. And I also want to take a liberty to say that, my soon-to-be brother-in-law, he's just finished transition. And this is a process that takes years. It's grueling. It's emotionally draining. It's physically draining for the individual, for families. So being able to have this in statute and insulate folks is incredibly important. So thank you again, Senator Scheibel, for bringing it forward.
Caller with the last three digits of 751. Please slowly spell and state your name for the record. You have 3 minutes and may begin. Caller with the last three digits of 751. Please press *6 now to unmute yourself. Caller with the last three digits of 090. Please slowly state and spell your name for the record. You have 3 minutes and may begin.
Good morning, Madam Chair and members of the committee. For the record, Chelsea Capurro, that's Chelseea, last name Capurro. Here this morning on behalf of the Health Services Coalition. I think we just first want to start by thanking the sponsor and everyone working on this bill. Everyone's been great to work with. We're here in support, but are still working through an amendment with the senator. As I mentioned, she's been great, and we hope to get to a point where we can come to an agreement on amendment and look forward to continued conversations.
Caller with the last three digits of 271. Please slowly spell and state your name for the record. You have 3 minutes and may begin.
Hello, my name is Cy Burnaby, S-Y, last name Bernabei. I am with Gender Justice Nevada. We are a local advocacy group for trans, non-binary, and gender non-conforming people in Nevada. I myself am a trans and non-binary person. I personally paid out of pocket close to $9,000 for my recent top surgery because I just didn't want to go through the mess of dealing with private insurance or other payees, so I paid out of pocket. I want folks to know that this is not something that trans and gender nonconforming people do lightly. It is an act of bravery to begin social and medically transitioning. I very much appreciate the work that Senator Scheibel and that Brooke have done in bringing this to your attention. Personally, I've been working over 20 years in this community. I have seen depression, self-harm, and yes, suicide when gender-affirming procedures and hormone therapy are not covered by insurance, and making healthcare not as accessible increases those things. Living authentically is the most important thing that we can do. Gender dysphoria is real. And for those who might not understand the experience of trans folks or what gender dysphoria means, I would invite you to any of our trainings or any of our discussions that we have talking about the trans and gender non-conforming community. Again, I work with Gender Justice Nevada. You can reach out to us or you can email me or you can call me 702-324-1271. And thank you very much. We very much support this bill and looking forward to how much this will help our community. Thank you.
Caller with the last three digits of 442. Please slowly spell and state your name for the record. You have 3 minutes and may begin.
Good morning, Chair Spearman and members of the committee. For the record, this is Nicole, Nicole, Willis, Willis, -Grimes, Grimes. With the Farrar Group, I'm here speaking on behalf of Silver Summit Health Plan, and we just wanted to be on the record in support of SB 139. Thank you.
If you recently just joined us, we are currently in support of SB 139. Please press *9 now to take your place in the queue. Caller with the last three digits of 159. Please slowly spell and state your name for the record. You have 3 minutes and may begin. Caller with the last three digits of 159. Please press *6 now to unmute yourself. You may begin.
Good morning. My name is Amy, AIMEE. Holdridge, HOLDREDGE. Thank you, Madam Chair and members of the committee. I'm a cis woman of color, mother of two, 10-year resident of Nevada, Clark County, and a CCSD parent, volunteer, and an organizer. I'm not trans or gender diverse, gay or intersex, but I know my life is better because of transgender non-conforming members of, or gender non-conforming members of my community. I am a human being just like my trans brothers and sisters. Trans folk are worthy human beings just as we all are. They deserve the equity many of us, even a cis Black woman, are afforded more often than they are. I want to live and contribute to a state that cares about all of its residents, that works to protect all of its residents, and I want to raise my kids in a Nevada that enacts legislation to ensure those protections are for all Nevadans. Thank you. I hope that we pass this bill in some shape, way, or form. Thank you again.
Caller with the last three digits of 338. Please slowly spell and state your name for the record. You have 3 minutes and may begin.
Good afternoon, or I'm sorry, good morning to members of the committee. This is Priscilla Maloney, Priscilla Maloney, representing the AFSCME retirees. Can I be heard okay? Is everything coming through? If somebody could just confirm that I'm being heard.
Caller, we can hear you.
Yes, ma'am. Please proceed.
Thank you. So the AFSCME retirees, most of whom, if not all, are members of the PEB program in one form or another, either as retirees on the Medicare exchange or non-Medicare retirees in the regular PEB program. We are in support of this bill. Briefly, I would like to note that it was discussed yesterday at the PEB board's legislative tracking board meeting. That's a special meeting they just have during the sessions where they go through the bills they are concerned about. The only discussion around this issue of SB 139 regarded costs, and there was certainly some robust concern debate about the initial findings from the program. It was a modest cost under any circumstances, but even that may be subject to some revision as we in the Public Employee Coalition asked for further clarification on that cost, feeling that along with the subject matter experts who testified yesterday that cost was somewhat exaggerated for the bill. I'd like to make sure that the committee understands that these are services globally in SB 139 that are already covered under PEB. There's just a couple additions within the bill, and hopefully somebody from PEB may be able to clarify this for the committee that would add these additional costs. So these, again, globally are services already covered. And then finally, I'd like to add on a personal note that just in the last 10 days, I myself got a phone call from a loved one whose family is going through treatment for one of their individuals for gender dysphoria. And the reason they called me, a cis older woman, was because I had had a medically required mastectomy for cancer 6 years ago, and they wanted to talk to me about the procedure. And I can't stress enough that having a good treatment plan, whatever your life situation is really, really important to somebody's recovery and in this context, to someone's transition into a happy and healthy and meaningful life in our society. So on a personal note, not speaking for the AFSCME retirees, I am very much in support of this bill, and I was very touched by the phone call I got asking me important questions,
Caller,
things
your time
like
is
nerve
lapsed.
damage. Thank you. So that's all I had to say about that. So thank you for your time, committee.
Thank you. If you recently just joined us, we are in support of SB 139. To testify in support, please press star 9 now to take your place in the queue. Caller with the last three digits of 751. Please slowly spell and state your name for the record. You have 2 minutes and may begin.
Hello, I'm Brady McGill. It's BradyMcGill. I'm the president of Las Vegas Pride, and we're here in support of the bill. And we support this and other measures that we can take and support to expand access for minority groups as it helps us all. Thank you.
Chair, you have no more callers in support at this time.
Right, we will move to those in opposition. Same thing, 30 minutes, 3 minutes per individual.
To testify in opposition of SB 139, please press star 9 now to take your place in the queue. Caller with the last three digits of 261. Please slowly spell and state your name for the record. You have 3 minutes and may begin. Caller with the last three digits of 261. Please press *6 now to unmute yourself. Please begin.
Hi, good morning, Chair Spearman and Senate Committee on Commerce and Labor. I actually put myself in queue for in favor, so just wanted to make that very clear. If I can still testify for in favor.
Go ahead.
Thank you, Chair Spearman. Thank you for this time. For the record, my name is Jasmine Margarita Tobin. Last name T as in Tom, O as in Oscar, B as in boy, O as in Oscar, N as in Nancy. I am an organizer with Planned Parenthood Votes Nevada. Planned Parenthood Votes Nevada is in favor of SB 139. Access to health care is a critical issue. Many LGBTQ plus people, especially transgender, two-spirit, intersex, non-binary, and gender non-conforming individuals, have long been denied their rights for medically necessary treatment despite the ACA mandating equal coverage for transgender affirming procedures. Their identity does not exempt them from the necessity of healthcare. It instead exacerbates the barriers to receiving healthcare. Trans, non-binary, and gender non-conforming folks are subject to greater hurdles to healthcare, including and especially those who are low-income, unhoused, living with chronic illness, or have pre-existing conditions. Vulnerable groups require healthcare based on medical necessity and must not be denied based on external biases and discrimination. SB 139 would address and expand healthcare access and disparity for Nevadans and create a more equitable healthcare system. This bill would quite literally save lives. Thank you again for your time.
Caller with the last three digits of 751. Please slowly spell and state your name for the record. You have 3 minutes and may begin. Caller with the last three digits of 751. Please press *6 now to unmute yourself. Thank you. You may begin.
I actually spoke in favor of this bill.
Thank you. We are currently in opposition of SB 139. To testify in opposition, please press *9 now to take your place in the queue. Caller with the last three digits of 510. Please slowly spell and state your name for the record. You have 3 minutes and may begin. Caller with the last three digits of 510. Please press *6 now to unmute yourself.
I'm the Lyon County Comptroller. This is Josh Foley, Joshfoli. I'm the Lyon County Comptroller. I apologize. It takes a while for this to register that I'm unmuted, but I think I'm live now. I'm speaking against this for a couple of reasons. Number one, I believe from a fiscal standpoint, and that's all I'm going to address, that this is one of the more expansive bills or laws that's proposed across the nation. Just so you're aware what that does to insurance rates, and I know when you take a look at it as a percentage of a very large plan, it can be a very small percentage, some of the things that we're talking about here. But when you take a very small plan, as an example in Lyon County, when we had a single person go on Humira, which is a common prescription that's out there, we had a significant increase in our insurance from year to year. So to give you an idea, last fiscal year we had a 15% increase in our health insurance rates, and we have to pass that on to our members that have dependent care coverage. We currently subsidize 30% of their dependent care coverage up to a cap of $250. Our rates are going up another 10% this year. That's what the existing coverage is. So I know that this is a very challenging plan or bill to get your arms around what's medical necessary and what is not, and people taking advantage of it, as we've had testimony. My only 2 cents worth on this is it has a disproportionate impact on smaller health insurance plans for smaller entities out there. And if we can keep the language to where it is really just to what is medically necessary and not be expanding significantly some of those different definitions, that's what my testimony is today. And I appreciate your time. Thank you.
If you recently just joined us, we are currently in opposition of SB 139. To testify in opposition, please press star 9 now to take your place in the queue. Chair, you have no more callers in opposition at this time.
Okay, so we will open it up to those in neutral. And just want to clarify, there was a person at the beginning who said that they signed up for in support, but weren't able to get in. We still had 8 minutes left on that, and that's the only reason I allowed that testimony to be heard. So we still had 8 minutes on that, so I wanted to clarify that. So let's go now to those who are speaking in neutral, please.
Testify neutral on SB 139. Please press star 9 now to take your place in the queue.
Morning, Chair Spearman and committee. Again, my name is Dwayne Young. For the record, I am the Deputy Administrator for the Division of Healthcare Financing and Policy. I won't belabor the committee as I have provided some clarification earlier. I do want to just speak to the most immediate, is that Nevada Medicaid has probably covered these services since 2017. There is some language in the bill which there are providers that we cover, but it says without limitation. And so those providers perform other services that are not currently covered in our policy, as well as some providers such as voice therapists that are not currently in our policy that have been added to the language of this bill. We have worked with Senator Scheibel on some potential language, and we're also aware, while I'm here representing Medicaid, we know that other state agencies such as PEB builds their policies based off the coverage of Medicaid, and so we have been communicating with them as well. And so we recognize that this does have a small fiscal note of less than $1 million total computable and exactly $214,000 over the biennium in state general funds. And so we look forward to continue working with the senator and all those who have spoke today in support to get this into a place that aligns with policy, but also the objectives to provide equitable coverage for these all populations across Medicaid. Thank you.
If you recently just joined us, we are in neutral testimony for SB 139. To testify neutral on SB 139, please press star 9 now to take your place in the queue. Caller with the last 3 digits of 523, please slowly spell and state your name for the record. You have 3 minutes and may begin.
Good morning, Madam Chair. My name is Tom Clark. That's TomClark. Here on behalf of the Nevada Association of Health Plans, to reiterate the sponsor, Senator Scheibel, at the beginning of the hearing, we are continuing to work with her on this important legislation. We're in the neutral position and hope that we can work with the senator and with the other stakeholders to come up with amendments that can make it a piece of legislation we can all support. Thank you, Madam Chair.
To testify neutral on SB 139, please press star 9 now to take your place in the queue. Caller with the last 3 digits of 874, please slowly spell and state your name for the record. You have 3 minutes and may begin. Caller with the last 3 digits of 874, please press star 6 now to unmute yourself. Thank you. You may begin.
Hi. Hi, for the record, Cristina Hernandez, Cristina, Hernandez, Hernandez, and just calling in for support for the bill.
Chair, you have no more callers that are neutral at this time.
Okay. Thank you. Any of the committee members have additional questions? I don't see any hands going up. Senator Scheibel, just a couple of things that I heard. One of the gentlemen who was in opposition mentioned increased insurance rates. So if possible, and I've heard what Mr. Young had to say, but perhaps you all might be able to get some type of actuarial component of this that shows this is what it is, this is what it would be, and if and try to get that to the committee members, because I think that's a valid point. So if you could get some type of actuarial comparison, that would be helpful. I also want to mention, I think it might be the same gentleman, that costly for smaller companies that have insurance, so you may consider some type of a floor as part of the negotiations. And I just want to say that there may be some who have listened to testifiers on this bill and listened to the presentation of the bill, who may think that the psychological abuse that transgender people go through is not real. So I'm just going to share with you something that happened a couple of years ago when I was called by an individual, a pastor who called me because they had one of their parishioners in a rehabilitation center, and the person was recovering from being shot. It was hate crime. And the place that the person was, although this person had the new name and the new gender on all of the records, the place that the person was refused to do that because it was, quote, they didn't like it. They didn't think that was correct. So they didn't treat this person in accordance with their identity, with their gender identity. There were some medical people who refused to change the Band-Aids or the bandages on this person's wound, and the person's mother had to fly in so that they could get the help that they needed. When they called me, I immediately called Mr. Whitley, and to his credit, in less than 24 hours, that particular facility, which was receiving Medicaid funds, understood that what they were doing was not correct. So the pain and the trauma of being ridiculed, of being ignored, or whatever, for transgender people who are seeking some type of solace, that is real. Having said that, Senator Scheibel, do you have any closing remarks? It is now day 3 of the hearing.
It does feel like day 3 of the hearing. I do want to thank everybody for their patience and for hearing all of this testimony. I have to make one small clarification on the record that the Nevada Association of Health Plans is in neutral. We are working on getting them to support, and I'm very confident that we will be able to do that. And finally, I just want to say that I think you have heard some very compelling testimony today. I would like to remind the committee that when we don't treat gender dysphoria, we end up treating the symptoms of it in treating people for other mental health crises, treating people for suicidal ideations, and in the very worst cases, we end up paying the completely incomputable cost of suicide of young people, adults, old people. Anybody can be affected by gender dysphoria and the effects of not having it properly treated. So I appreciate the attentiveness. I will stop talking so we can move on to the rest of the committee's business. And I look forward to continuing to work with all of the stakeholders and anybody here who wants to follow up offline on their specific questions or concerns.
Thank you, Senator. And absent any additional questions or comments from committee members, I will now close the hearing on Senate Bill 139. And we will open it up now for public comment. Public comment, those who are on the telephone and would like to comment. Broadcast, take a couple of minutes to let you get set up and then.
Senator Spearman, one moment.
Oh. My bad, we did. It's been so long. Senate Bill 196. I am so sorry. So we'll come back to public comment and let's open it up now for Senate Bill 196. Senate Bill 196. Those who are here to present on that, we're still here. You're invited to go first, and I'm sorry that's one of our committee members, Senator Lang. Please forgive me. Senator 196 prohibits the performance of public examination in certain circumstances. So, Senator Lang, please begin.
Thank you, Chair Spearman. We're all good. I'm here to present Senate Bill 196. It prohibits the performance of a pelvic examination in certain circumstances. Good morning, Chair Spearman and the committee. I'm Roberta Lang, representing Senate District 7 in Clark County. Thank you for the opportunity to present Senate Bill 196, a bill that seeks to prohibit healthcare providers from conducting public examinations on patients without their informed consent. A little bit of background, healthcare providers are required to obtain informed consent from patients to provide medical treatment. However, currently state law does not prohibit providers or medical students practicing under their supervision from performing public examinations on anesthetized and unconscious female patients. And while it may be surprising, this appears to be a common practice. In a New York Times article published on February 17, 2020, a nurse in Arizona outlines her unsettling experience after being admitted for stomach surgery. The nurse, who has a history of sexual abuse, reported having panic attacks and triggering traumatic memories after she learned that a resident conducted a pelvic exam while she was unconscious. This after explicitly telling her physician that she did not want medical students to be directly involved in her surgery. This story is just one of many that have led states across the nation to consider or pass legislation requiring informed consent for public exams. In fact, the issue is so pervasive that women have begun sharing their stories with the hashtag #MeTooPelvic. While medical teaching is crucial and training medical professionals to identify normal and abnormal anatomy is necessary, some exams by their very nature are intimate and invasive. A study published in The Lancet found that 100% of women reported that, quote, they would prefer to be asked before their pelvis is used as a teaching tool, quote. The pelvic exam performed without a woman's consent in any other context is considered sexual assault. Senate Bill 196 does not prohibit performing pelvic examinations when they are necessary, nor does it prohibit instruction of medical students to perform this exam. Instead, the bill requires obtaining the informed consent of a patient. Section 1 prohibits healthcare providers from performing and supervising examinations they are not appropriately licensed, certified, or registered to perform, and that are not within their scope of practice. Section 1 also prohibits healthcare providers from performing or supervising public examinations on anesthetized and unconscious patients without first obtaining the patient's informed consent unless, number 1, the public examination is within the scope of a surgical procedure or diagnostic examination to which the patient has given informed consent. 2, the patient is unconscious and incapable of providing prior informed consent, and the public examination is required for a diagnostic purpose and is medically necessary. Or 3, the patient is unconscious and an alleged victim of sexual assault, and the physician or physician's assistant reasonably concludes that the exigent circumstances justify conducting a forensic medical examination. In addition, Section 1 prohibits a person who is not licensed, certified, or registered as a healthcare provider and who is working under the supervision of a healthcare provider, such as a student or trainee, from performing or supervising a public examination that the supervising provider of the healthcare is prohibited. These unlicensed individuals are also prohibited from supervising the performance of a public examination if conducted by a person outside the immediate presence of his or her supervising provider of health care. Finally, in sections 2 through 12, it authorizes the imposition of professional discipline or denial of a license or certificate for providers of health care who perform or supervise a public examination when prohibited. In closing, I would like to thank Chair Spearman and committee members for hearing SB 196. This is important legislation that has the support of many medical professionals. Currently, 15 states have banned unauthorized public examinations, and 7 states have introduced similar language in 2021. On one final note, I'm happy to have worked with former Senator Ivana Kinsella on this legislation and Senator Joe Hardy. I hope you'll all agree with us that codifying in statute the requirement to obtain a patient's informed consent is vitally important for women in Nevada. And then, Chair Spearman, I have a letter from the ladies who asked us to bring this forward, if I could read that letter. It says, Dear Senators Lang, Hardy, Hammond, Scheibel, Donate, Harris, Orenshaw, and Gansert, we are writing to express our strong support for Senate Bill 196 and to thank the sponsors and co-sponsors of the bill. We first heard of the practice of medical providers and medical students conducting public examinations on women under anesthesia without their consent in 2019. It was hard to believe that this practice is legal in most states. We contacted Senator Ivana Kinsella and asked her to introduce a bill that would prohibit this practice in Nevada. Under anesthesia, a patient no longer has control over what happens with their body. While we understand that the public examination is a critical tool for diagnosis of women's health conditions and an important skill for students to master before becoming physicians, it becomes an intrusive exam when, if not medically necessary, performed on an anesthetized patient without the express consent. Patients should have the freedom to decide from whom they receive treatment and what aspects of their medical care will be performed by a student or students, particularly if they were not awake during the treatment. This legislation improves the process for obtaining, documenting, and ensuring consent for examination under anesthesia and supports patients' freedom to make informed decisions about their medical treatment. Thank you for supporting this informed legislation, Christine Smith and Terry Greenman. I also received a note from Susan Fisher. She had to get off the call. She says the Nevada State Board of Osteopathic Medicine voted in a public meeting to support SB 196. And she will try and call in later, but in case she doesn't, she wanted you all to know. And with that, I'm happy to take any questions.
Thank you, Senator Lang. And just for clarification, the letters that you read were part of your presentation, correct?
Yes, ma'am.
Okay, all right. Do you have anyone else presenting with you?
No, ma'am.
Okay. So I'll open it up now to questions. I think I saw some. And then Senator Pickard, Senator Hardy. Elmar?
Thank you, Madam Chair. I appreciate this. I think this is a good bill to try to address the issues. We unfortunately in Carson City area back in the late 90s had a doctor that was a dentist who was terrible. Anyway, so in that respect, will this cover all actions, or is it just dealing, does it help strengthen or enhance the problems that are occurring in this realm? I don't know how to even say this, I apologize. Dealing with just public exams, or is it other, will it help curtail other bad actions?
Thank you, Senator Selmayr. So this bill specifically deals with pelvic exams.
Okay, maybe I'll discuss other issues that we know of offline then. Thank you. Appreciate it.
Senator Pickard?
Thank you, Madam Chair. I'm going to ask the same question I asked in the last hearing. Is this not already law? I know there was the comment made that it's legal in many states, but I seem to remember many cases, even those that reached the Nevada Supreme Court, that have held that this sort of thing was violative of the law. So this is not currently illegal?
Thank you, Senator Pickard. Currently, in teaching hospitals, this is a practice that seems to be done all the time and is legal under a teaching hospital. And so what this bill is trying to do is to say in Nevada, this is not okay, and that you must have the consent of the woman first, and that I listed the 3 circumstances of which it would be okay. So right now it is legal for people to do it. We want our doctors and student doctors, and we want to make this a practice where you have to get consent. It's not okay just to do it on your own, do it no matter what. You have to get consent first.
Right, I appreciate that. And since Dr. Hardy works at a teaching, a medical school, it would be interesting for me to get his take on this. I know that one time I underwent a procedure at a teaching hospital, and I had to sign an informed consent form that allowed for students to be present during the procedure, which I did. I didn't have a problem with it, but I wonder if this then needs to be specific as to those informed consents, that they have to specifically address the issue as opposed to a blanket informed consent form, similar to the one I seem to recall signing. That might be something to address, because my fear is if the goal of this bill is to make the exam specifically require the informed consent, that if someone were to sign a blanket informed consent form that doesn't specify it, did it actually meet the requirement? So that might be something to consider on the legal side of this. Thank you.
I appreciate that. Thank you.
Thank you, Senator Hardy, and I believe Vice Chair Neal has a couple of questions.
Thank you, Madam Chair. Obviously, the focus is taking advantage of people who are anesthetized, and people who are anesthetized cannot give permission, and so it becomes somewhat problematic getting permission from an anesthetized person. I would like to clarify that medical residents are not students, they are physicians, so they are in a different system. But bottom line is, dentists have no business doing pelvic exams, no matter how many forms they sign, it's okay. And dentists use laughing gas, and so they would get into big trouble, and appropriately so if they so did. When the physician who is mentoring, teaching, precepting a medical student, even whether the medical student is there or not, the physician practice always has someone with the physician, whether they be male or female, so that the person is not intimidated by one person. The practice is you always have two, and the person is awake, and the person knows what you're going to do and the reasons for it. So to have a separate form, that you're going to do a pelvic exam, may be a little redundant because in the process of the office visit, because these are in offices, not in surgical suites where somebody is anesthetized, unless they're undergoing surgery and you're looking for a mass after you've been doing your laparoscopic surgery and you want to figure out, how extensive that is. So the things that you sign for surgery allow some flexibility that you are not going to wake up somebody and then I do a pelvic exam. And these exams you're doing in an operative suite are never alone. You are not putting somebody to sleep all by yourself. You have nurses, you have anesthesiologists, you have the doctors. So this is trying to get at a specific problem. And I think this bill gets at a specific problem and makes the person who crosses this liable for her very license. And I think that there can hardly be anything more motivating than you'll never be a doctor again in your whole life if you do this. So it's, I think it's something that is very respectful of the woman, whoever the woman may be, that we make sure that she not only awake, but she knows what doctors are doing. And if it's in a teaching setting, that there will be a medical student or a resident that's participating in this care. I don't know if that's too verbose or if it gets to your question, but that's the practice that happens.
Well, I appreciate that. I was thinking more along the lines of if we had, you always do the informed consent at the beginning and, while the patient is awake. And my concern is if we allow for a blanket informed consent form without specifying that this would require separate consent within that form, it might provide a loophole that we want to avoid. So that was it. But thank you. I do appreciate that response.
Thank you, Vice Chair Neal.
Thank you, Madam Chair. So I had a question on Section 2. So it's Section 2, line 37, where it comes under, grounds for disciplinary action. And so it said, or supervising the performance. And so that's the part that I want to try to understand is, are we allowing, because I was listening to Senator Hardy, and so this is what I don't know the answer to. Are residents considered to be, do they get registered or are they licensed? And is this contemplating that they have a supervising doctor and then the resident is there and then they're trying to learn or understand like fibroids? Because it says or supervising. So I'm just trying to get an understanding on this bill.
Chair Spearman, could I defer to Senator Hardy to answer that?
Sure.
Thank you.
Senator Hardy, and when you answer, can you get a little bit closer to the mic?
Appreciate it. Thank you, Madam Chair. Thank you, Senator Neal. The resident is somebody who has gone through medical school, and the last 2 years of medical school have been what we call clinical rotations. At least one of which has been in the field of gynecology, obstetrics. And so you, as a medical student, when you come out, you know how to do a pelvic exam. And as a resident, you are a physician. You are an MD or a DO. And you then in residency are in a position to be supervised but not necessarily doing the same pelvic exam that the attending, what we call the attending physician, would do. So you don't have to have two people doing the exam to ascertain what is happening. Now, it may be that the resident will say, I noticed something that I'm not sure about, and the attending physician will say, okay, show me or let me examine the patient. So, but the resident, by the time they get into residency, has become maybe not as good as estimating the size maybe of a 6-week uterus, but they are able to say this is larger than I thought it would be if they weren't pregnant. Telling the difference between a 6-week uterus and an 8-week uterus may be a little more refined than a medical student coming out of medical school who's now a resident would be able to tell. But the resident is a physician and is licensed as a resident physician. And then at some point in the residency, some states allow for a resident to have a unlimited license, which is what I did after my second year of residency. That was in Arizona. So the licensing and credentialing happen through your residency program, where the resident is under the supervision of attending physicians, and that's how that works. And I don't know if I've said too much or not enough.
No, that was good. That was good. So I appreciated that. I was just trying to get the mechanics down. Thank you.
Thank you. Senator Hardy, is that your hand up or again, or yes? Well, you just didn't lower it from last time.
I was basically going to say the role of a resident because the resident was alluded to in the initial comments by the sponsor, wanted to make sure that there was a differentiation between a resident and a student. Thank you.
Thank you. Any additional questions from committee? Okay, so with that, we'll go into those who are in support. It'll be 30 minutes and 3 minutes per person. So broadcast, it's up to you now.
Thank you, Chair. To testify in support of Bill SB 196, please press star 9 now to take your place in the queue. Caller with the last 3 digits of 540, please slowly spell and state your name for the record. You have 3 minutes and may begin.
Good morning, Madam Chair and members of the committee. My name is Serena Evans, SERENAEVANS, and I'm the Policy Specialist for the Nevada Coalition to End Domestic and Sexual Violence. We want to applaud Senator Lang and all of the co-sponsors for SB 196, and we are here in support of the bill. The coalition has been working with sexual assault advocates and programs throughout the state to examine Nevada's sexual assault and associated statutes, and consent is an important part of that work. Specifically in the context of consent, this ongoing work group has had conversations around medical consent and the unfortunate victimization that occurs through uninformed pelvic exams. Pelvic exams are intimate, invasive, and can be very uncomfortable and have lasting effects. Every individual should have the right to give informed consent to what happens to their body during any medical procedure. Consent to one medical procedure does not mean consent to all medical procedures, and many individuals may not be comfortable being used for learning purposes. Informed consent is an essential part of empowering and protecting patients as they undergo medical procedures. Unconsented pelvic exams can be incredibly traumatizing and violating, especially to a patient who may have had previous sexual violence victimization. It should not be necessary to have to enact protections to prevent patients from becoming victims of sexual impropriety or assault, but unfortunately, that is the reality of the world we live in. Patients, athletes, and others are at risk, not only from medical providers, excuse me, but also from physical therapists, coaches, and others in whom they place trust. Everyone should feel safe and empowered in seeking medical care, and we must not allow providers to take advantage of vulnerable patients. We at the Coalition will be working through the interim and beyond to work on other aspects of the sexual assault definition and consent language, but Senate Bill 196 is an excellent first step in addressing medical informed consent, and we encourage the passage of this bill. Thank you so much.
Caller with the last three digits of 080. Please slowly spell and state your name for the record. You have 3 minutes and may begin.
Thank you, Madam Chair. For the record, my name is Susan Fisher, SUSAN FISHER, with McDonald Carano, speaking this morning on behalf of the Nevada State Board of Osteopathic Medicine. I appreciate Senator Lang putting the earlier comments on the record. I wasn't sure that I was going to be able to be done with my other meeting in time to get back, but you went long enough that I was. The board expresses its appreciation to Senator Lang in bringing forth Senate Bill 196. As one board member said during our public hearing the other night when we discussed the bill, we shouldn't even have to be discussing this and putting this in statute, but unfortunately we do need to. And as Senator Hardy pointed out, this puts bigger teeth into the statute. So we do appreciate Senator Lang's efforts in this, and we encourage passage of Senate Bill 196. Thank you.
We are currently in support of SB 196. To testify in support, please press star 9 now to take your place in the queue. Chair, you have no more callers in support at this time.
And we will go now to opposition. 30 minutes, 3 minutes per person.
To testify in opposition of SB 196, please press star 9 now to take your place in the queue. Again, to testify in opposition of SB 196, please press star 9 now to take your place in the queue. Chair, you have no callers in opposition at this time.
Thank you. So we will go now. We'll go now to those who are in neutral.
To testify neutral on SB 196, please press star 9 now to take your place in the queue. Caller with the last 3 digits of 662. Please slowly spell and state your name for the record. You have 3 minutes and may begin. Caller with the last 3 digits of 662. Please press star 6 now to unmute yourself. Thank you. You may begin.
Good morning, Madam Chair and members of the committee. My name is Jeanette Belz, JeanetteBelz. I am calling on behalf of the Nevada State Board of Occupational Therapy. Just wanted to verify in conversations, hopefully with Senator Lang, that this bill does not impede the ability of graduate level occupational therapists to get an additional certification in pelvic evaluation. And this is because the bill amends Chapter 640A. So we do look forward to discussions with Senator Lang to clarify that. Thank you very much.
We are currently taking testimony in neutral of SB 196. To testify neutral, please press star 9 now to take your place in the queue. Chair, you have no more callers neutral at this time.
Okay, thank you. Committee members, additional questions? I just saw Senator Hardy. Yes, sir.
Thank you, Madam Chair. I'm at a loss for words. What does this bill have anything to do with public exams by occupational therapists?
So Ms. Bells may not be on right now. She may have hung up. Senator Hardy, can you follow up with her offline and then bring the answer back to us? And perhaps, Ms. Bells, if you're still listening, you can provide a written response so that other committee members will know the answer and we can post it as part of the discussion, Ms. Bill.
All right, thanks.
Okay, thank you. Committee members, any additional comments, questions? Senator Lang, you have closing comments?
Thank you, Chair Spearman. I thank you all for considering this bill. I think it's really important. A woman's body is her own, and she should have the first right to be able to say, I do or don't want a pelvic exam. And so I think, as was mentioned earlier, this is a great first step in creating something in Nevada statute that deals with this issue. And so I look forward to working with all of you and getting this bill out of committee and passing on to the Assembly. Thanks so much.
Thank you. And with that, we will close the hearing on Senate Bill 196. And now we will go to public comment.
Madam Chair, 1 second.
Now, do we have the amendment for SB 100?
Madam Chair, this is Cesar Magrejo, Community Policy Analyst. Yes, we have the amendment. It was emailed to each of the members, and it is now available on Nellis.
Okay. So then why don't we go on in work session Senate Bill 100 before we go to public comment. Senator Severs-Gansert is still with us.
Thank you, Madam Chair. Yes, I'm still here.
Mr. Mayor,
discuss the amendment.
Okay.
Thank you, Madam Chair. Senator Severs-Gansert, I'll run through the work session document, and then I include the additional amendment, and if there's any questions, we can follow up. For the record, Cesar Magrejo, Committee Policy Analyst. Senate Bill 100 is sponsored by Senator Severs-Gansert, and it was heard on March 5th, 2021. Senate Bill 100 enacts the Physical Therapy Licensure Compact, and there were amendments provided during the hearing of this bill by Nina Laxalt, and they are attached to this work session document. First Amendment deletes subsection 2 of section 3, which requires that a physical therapist or physical therapist assistant practicing in this state under a compact privilege be deemed to be licensed to practice as a physical therapist or physical therapist assistant as applicable in this state. The Second Amendment is amend subsection 1 and delete subsection 3 of section 4 to remove language providing that the board issues written authorization granting the compact privilege, because the granting of the compact privilege is accomplished through the compact itself. The revision of subsection 1 will require corresponding revisions in sections 3 and 4 to remove references to written authorizations, and a corresponding revision in subsection 1 of section 3 to remove the reference to the compact privilege being issued pursuant to Nevada Revised Statute 640.110. A Third Amendment is to amend subsection 4 of section 4 to clarify the acceptable documents that a physical therapist practicing in this state under the compact privilege must display in a location that is accessible to the public. The proponents of this bill noted that physical therapists granted a compact privilege do not receive a formal certificate or document. And the last amendment in this work session document is to amend subsection 5 of section 4 to delete the authorization for the board to charge a fee to change a name in the written authorization, as the board will not be providing that authorization. And the amendment that was submitted today that is on Nellis and emailed to the committee members is an amendment to section 2 of the bill, which is the Physical Therapy Compact, Article 7, Section 7, and the amendment will include the addition of language that nothing in this chapter provides immunity from civil or criminal liability for any act or omission resulting from the negligent conduct or intentional misconduct by any licensee, physical therapist, or physical therapist assistant. And Madam Chair, that's all the amendments.
Thank you, Mr. Melville. I see Senator Settlemeyer. Question?
Thank you, Madam Chair. I appreciate it, and I just wanted to make sure that the sponsor is okay with the amendment. And in that respect, I have no problem supporting it. It seems a reasonable amendment. I am rather troubled by the lateness of this amendment. I hope this does not become a common practice of individuals to give amendments at such a late state to the sponsor. I find it very problematic that this occurred. I don't necessarily have a problem with the amendment, but just in the procedure that was brought forth.
Thank you. Senator Sievers-Gansert, response.
Thank you, Madam Chair. For the record, Senator Heidi Sievers-Gansert, and we consider this a friendly amendment. It's just a clarification about immunity related between members and licensees. That we wanted to make sure it was a little bit clearer. And again, that's in Article 7, Section 7. Thank you.
And Senator Sotomayor, if I might chime in, they contacted me. I know that they were working on some language, and I think Senator Sievers-Gansert said that, answered one of the questions when we heard the bill about what that would look like in terms of the qualifications. So they called me yesterday and said that they had come to a kumbaya, and we just needed to get, so I asked just to get the amendment. So that's what happened. She was working with the stakeholders to make sure she answered that question about the language. So,
I appreciate that, Chairman. If there, whenever there is the appropriate time, I would recommend amend you pass with all the requisite amendments. I do still believe, though, that anyone that actually proposes the amendment after the committee starts should be admonished, and because this didn't necessarily come from the sponsor. It came from an outside source. And while the amendment is agreeable and is not problematic, it's just the concept of the process that bothers me. Thank you, Chair.
Thank you, sir. Duly noted. Senator Pickard.
Thank you, Madam Chair. I agree wholeheartedly with Senator Settlemeyer as to process. I just, as I got this, I was expecting something fairly significant. And when we're talking about Section 7, we're talking about qualified immunity from activities. It's within the scope of the commission employment duties or responsibilities. I don't even see how this is necessary or frankly germane to this section. So I'm not going to ask Senator Sievers-Gansert for a response as much as if the proponent of the amendment would please explain, put something in writing. We can put it in the record as to why they think this is necessary, particularly given the amount of time this bill has been in process and the custom that we have of 24-hour notice. I would like to know why they thought it was necessary to bring this at the last minute, given I don't think it's germane. I don't think it actually accomplishes anything with respect to this section, but I'd like to get a response from them at some point. Thank you, Madam Chair.
Thank you. Senator answered the organization that you all worked with. Are they still on the line or are they available? I'll tell you, let's do this. For those who have some heartburn with this, with the amendment or with the bill, whatever your vote is today, you can always say you reserve your right to change it on the floor.
Madam Chair, I would second Senator Settlemyer's motion. We're ready.
So we have a motion by Senator Settlemeyer to amend to pass. We have a second by Senator Hardy. Additional questions? Madam Secretary, please do a roll call, please.
Senator Hardy?
Yes.
Senator Lang?
Yes.
Senator Neal?
Yes.
Senator Pickard?
Yes.
Senator Scheibel?
Yes.
Senator Settlemeyer?
Yes.
Chair Spearman?
Yes. And I believe that the motion passes unanimously, amend and do pass. Senator Sievers-Gansert, we take the floor statement, but before we do the floor statement, just make sure you make the rounds with those who had some issues with either the amendment or the timing.
Thank you, Madam Chair and committee members.
Thank you. Third time may be the charm. So let's go now to public comment. Public comment. Broadcast, is anyone on the line for public comment?
Thank you, Chair. Let me stand by while I check. To speak in public comment, please press star 9 now to take your place in the queue. Chair, you have no one wishing to speak in public comment at this time.
Okay, thank you. Committee members, no comments, questions? Okay. Well, with that, it looks like we have covered everything that we came here to do and probably a little more. So I'm going to adjourn this meeting and we will be right back on Monday. Thank you all. Have a great weekend, okay? We're adjourned.